Good evening, everyone. Thank you for making time to be part of this webinar this evening. We're moving forward with an escalation in our policy towards universal masking, and we thought it was very important to not delay and have a webinar. This would be recorded this evening and will be posted on the hub for viewing at another time, as well as right now as a live webinar presentation for clinical and physician leaders. I'm going to pass it over to Kirsten Kroll, who's going to introduce the topic. We have a number of panelists, and we'll also have an opportunity for questions. Thanks very much. Kirsten, over to you.
Oh, it's actually Les that's going to kick it off, so I'll turn over to Les. Sorry,
okay.
folks, this is all a quick one for us, so we don't have this polished.
We're going to play a hot potato Easter egg, and probably on behalf of all of the executive team, would like to start with a very sincere thank you. We know there has been a ton of information and an awful lot of concerns and questions being asked by our frontline teams. And it's really our hope that we have a simple message to deliver this evening as people are here at 6 o'clock going into a nice 4-day weekend. So if I give some context, universal masking is the principle that everyone is wearing a mask within our organization, and particularly people wearing a mask who are forward facing, so in the face of our patients. So with that, there's some really key messages we would like for our teams. And most important is the concept of universal masking is dependent that we have supplies. And we need to be assured of our supply chain and that products will be there. So there is always a risk that we might have to revisit this policy. But in the interim, what can our teams do to help us be sure that we have the products we need? And you'll learn some information around continuing to support some conservation strategies, that we really want to empower people, that, you know, the plan is that they have a mask and they'll wear the mask for the duration of the time that they're in the hospital. But it's very dependent that we are all working together. In terms of clinical units, there will be a rollout that has already started with our highest risk areas, the emergency departments, the ICUs, our COVID positive units. There's a long list of those units. The education will roll out over the weekend to include all the rest of our clinical units. And then come Tuesday, we'll have to go back and do some education for the ambulatory clinics and services that weren't working the weekend. We are not addressing the areas that are administrative or not facing the patient areas, and we need to manage our personal protective equipment supplies and see where that will get us to by next week. So basically, universal masking, our teams, our porters, our EAs, our staff, our frontline teams, nurses and doctors will be wearing a mask at all times. We are instituting it across the organization, and the only people we have exception to right now would be administrative people who are not forward facing our patients and families. So with that, I think I'm handing over to Kirsten. Oh, I'm going to keep it. So a few key concepts, and I've already started, is we're confident right now that we have in our supply enough PPE to support people being handed a mask at the start of their shift. And the second most, which is really our most important principle, is we need to ensure that we always have the right supplies to support our COVID positive or our presumed COVID patients. So that will always be our first principle. As long as we can maintain our inventories, then we can continue to support universal masking. You'll hear some conversation from an educational perspective about creating a closed loop approach. And that is really about people recognizing when they have a piece of personal protective equipment, wherever possible, we are going to try to maintain and conserve that piece of equipment. There will be a lot more information coming out about conservation strategies next week. the message we're trying to go into the Easter weekend with is universal masking for front-facing teams, and the focus on conservation will, in some very 4 strategies, will really start to unfold next week. So lots of messaging that we're going to need leaders' help to help remind people around the principles of conservation. Okay. So Kristen,
Yeah.
you're taking this one.
I think this is mine. So
Oh, sorry, Sandy.
there's been a number of meetings to talk about conservation strategies. Normally, we don't reuse personal protective equipment. It's single use, but during the shortage that we're experiencing for this pandemic, we're following CDC guidelines and recommendations to help us conserve the PPE so that it's available for the duration of this pandemic. So extended use refers to the practice of wearing a mask or a face shield for repeat encounters with several patients without removing it. So you're wearing it for a long period of time, for the full time, maybe half a shift or before you go for break. When reuse refers to using the same mask or face shield for multiple patients, but removing it after an encounter, and then when you need to put it back on again, you would put it back on again. So there can be a combination of extended use and reuse, where you may have put on a mask and wear it for an extended period of time, and maybe for 4 hours, and then you take a break, and then you would preserve that PPE so that when you come back from your break, you would put it back on. So there's a combination, and there'll be training to assist with that. And then there's the reprocessing that's also being looked at, and that would be using some of the technology in MDRD to decontaminate personal protective equipment such as your mask, using that technology, and so that it can be reused again. And then the 4th one is personal protective equipment, and that would be individuals bringing in their own personal protective equipment. And I'm going to pass it over to Kirsten, and she can provide a little bit more context around that.
Thanks, Cindy. Hi, everybody. So the personal protective equipment, we know that people have been craving, and in some cases, perhaps even wearing their own materials. There will be more guidelines coming out around that. But right now, from the point of view of masks in particular, I'll talk about goggles in a moment, but masks in particular, we're really not pushing people to wear their own PPE to work, especially if they've been issued a device, a mask or other PPE at work. So again, those who are part of the patient facing, who are getting a mask given to them, they should wear that one. This might come up for individuals who are not part of this bucket of universal masking. So people like myself, where I might not be in a clinical area very much that day, but yet I still feel I can contribute to a reduction of transmission of disease. I could wear something like a cloth mask, for instance. It's a way of trying to reduce some of the transmission that might be going on between people when they don't even know they're infected, right? But really our emphasis on individuals who are still not part of this universal masking right across the organization, because we're, again, narrowing this down still to clinical related areas, patient facing. We need to continue to push the hand hygiene. That is fundamentally the best protection for people. That social distancing is the other key element. There are perhaps some areas that we're aware of that it is a little bit more difficult. So maybe people do want to wear a mask in those areas that are not patient facing. And again, of course, people doing their own screening every day to make sure that they haven't got any symptoms and are getting the attention that they need if they do have symptoms. But if people want to bring their own cloth or paper mask from home, we would certainly allow that to happen. So that hopefully gives you a sense of where we're kind of trying to say where it's acceptable. But again, in the patient-facing areas where we are providing PPE and so on, we do not really want to see any of that personal protective equipment. Again, goggles, a bit of an exception here. We know that are some areas, such as the emergency departments, where people have been getting their own goggles. Again, further language will come out on some materials about that, but certainly, yes, that would be fine. Again, they need to make sure that they're cleaning it with soap and water between patients and so on once they've left it or doffed it, I mean. So that's kind of where we're at with the personal PPE. Let's go to the next slide. So I'll turn over to Romaine and any of the other educators that are with us today to talk a little bit about the education plan.
Hi, it's Michelle Money here to talk about the educational plan. And I just need to adjust my screen to be able to read it. So currently to date, many strategies have been put in place to, I'm sorry, I just lost my information. Andrea, are you available to jump in?
Maybe Romaine.
I am here. It's Andrea. So we've been working to put together education materials to be able to support the staff over the weekend. There is educator support going to be on site every day this weekend, and then starting Saturday day shift and evening shift for Saturday, Sunday, and Monday.
Wonderful. Michelle's back. Can everybody hear me?
Yes.
Thank you. So the current conservation strategies, which we continue to have educated on, would be the removal of supplies of masks in public areas, the use of masks for essential procedures and surgeries when indicated, choosing the right mask for the right assessment and approach to the patient, cohorting of patients and bundling activities. And moving forward, we have 3 specific strategies, which we call our new conservation strategies. So the first one would be strict mask allocation. And this is limiting the use of procedure masks to 1 or 2 masks per person per day, depending on your assignment. We're strongly educating people that masks are less effective when wet, but they do not need to be discarded. They can be stored until dried for reuse. And this would be done corporate-wide except on high COVID risk units, that being the ICU, COVID wards, ED, and the UCC. Staff will be educated on the reuse process. They will be encouraged to bring in their own type of storage container, plastic preferred with a lid. And when storing the mask, they will be instructed how to keep the straps safe on the outside of the plastic container to reduce contamination. There is an excellent video that we will use corporate-wide. It'll be located on the hub, and it gives instructions on how to store masks, and those being N95s as well as surgical procedure masks. Our second conservation strategy would be the same-day reuse. I apologize, that's what I just explained. And then the third reprocessing is the reprocessing strategy of N95s and surgical masks. So that is for all dedicated mask users on COVID high-risk units, that being ICU, wards, ED, UCC. We're not going to discard masks upon doffing into the garbage. We're going to deposit them into a box for reprocessing. All in bright, colorful, easy to understand documents that will be considered unit-based resources, and they all fall into a very strategic order to support staff. Thank you.
All right, so it's Kirsten again. Hi. So just a bit of an overview that you've had around what is universal masking. I actually am going to turn to Dominic for a moment because he explains the difference between where we're at now and what universal masking is really intended to do. So Dominic, maybe just to pipe in for a moment, Dominic Mertz.
Yeah, thank you, Kristen. Yeah, I just want to go back to the concept of universal masking again. Leslie very nicely explained how it looks like. But I think we need to take a step back as well and ask ourselves, why are we doing this? And the main reason, in contrast, we usually use PPE to protect ourselves from patients. In the universal masking approach, it's first and foremost about protecting others from us. That's why we are wearing a mask, and only a mask. It's in case we are asymptomatic carriers or pre-symptomatic that we don't infect anyone else. In addition to that, of course, the mask also protects us to some extent from others, but it's a different concept or a different driver, I would say. And why now? I think the now is mostly based on a mix of how our local epidemiology changes and having enough supplies to do this. And the hospitals in the region felt we are there now in terms of our epidemiology, so we make it happen. And as it was already mentioned, we can make it happen, but we need to combine it with the PPE conservation approaches that we are outlining today. Back to you, Kristen.
Great, thanks, Dominic. Okay, so next steps you've heard. So educators will be out on Saturday, really trying to get this spread toward other units that haven't already had some exposure to universal masking. They will be talking about those conservation strategies, as Michelle nicely described. I've seen some of the materials. They're really, really cool, and the videos will be very helpful and simplify what we're asking people to do. We know that it has been a challenge trying to keep up with this. I don't want to underestimate also the importance of this, of how people are doing what's called that point of care risk assessment. Again, you always have to understand, okay, am I in front of a patient? What do I need to do to try and protect myself and then my colleagues? This morning to make them aware of where we're headed as well. So that was a collective table of the different union leaders and so on to make them aware. And a great question came up from the security person talking about what's expected of me, which was, I thought, a really great question. And again, this is a great example in that role. While a lot of their work is not necessarily patient facing, in other words, they're doing a lot of things on the campuses, site reviews or observations of things. But of course, if they're involved with patients to a more extensive degree, or in that among a team, like in the emerge department for a fairly extended period of time, of course they should be putting on that PPE just like everybody else. Again, go back to the principles of trying to keep each other safe in the spread of disease, but also making sure that we're keeping our patients protected. So again, some disciplines, some roles, even my own, I will have to make some judgment around what is my role in that area, how long will I be there, will I be in contact with patients, and using some good judgment. So we do need to make sure that people are trained effectively to do these judgments and also to follow the principles. So that, as I mentioned, the unions are aware. We did also raise with them, just so you're aware, some of the aspects of decontamination or reprocessing approaches that potentially we are exploring, just to make them aware, kind of get them ready to that. Not that we've implemented other than what Michelle described as, again, in some areas, especially our COVID related areas, that we are collecting masks right now because there tends to be a very high usage there, and we'll see what we can do with those down the road as far as reprocessing. So more to come on that piece down the road, but the unions have certainly been exposed to some of this. And of course, there's all sorts of nuances that come with those sort of things. But they understand the aspects. What's really important, that we are assuring people that they're getting the right PPE for the care of the COVID patient. So we should never hear in any of this that people did not have the right PPE to care for a suspect or a confirmed COVID patient. And that right now our conservation strategies are really trying to foster that closed loop. Again, how can we avoid losing a lot of our materials into the trash, and what can we do to keep them in our cycle until we have more assurances that our inventories are sufficient to keep us really strong and ready to respond to all these things that are coming our way. On the weekend, educators are here, but managers, we understand that sites have different kind of rosters of leaders on the sites, which is great. Help us to reinforce those messages. Certainly, if you're hearing that there's still a lot of confusion or issues that are coming up, by all means, let the educators know, and any of the leaders as well. Escalate it up to us, and we do have certainly the website to collect information and responses from people as well. There is an HHS memo to come out still today from Wes and from Michael Stacy, Wes Stephen and Michael Stacy, again with a snapshot picture of what is going on as far as our movement now towards universal masking. So on that note, I will echo also what Les introduced today, and that is much gratitude. It has been quite a few weeks. I think a lot of people are feeling pretty tired, but at the same time, I'm always so grateful for the talent and skills that are among our leaders, really trying to make sure that people are stepping up and really doing the right things for our patients. It's ultimately about our patients, but the strain has certainly been there. So I thank you from my heart as well for your leadership and your ongoing commitment. It's such a strong organization under these circumstances. So I'm going to turn over to Aaron, and he's going to help to moderate. If we can handle a few questions, we'll try and do that.
Thanks very much, Kirsten. So I do have a few questions. I'll ask them in the order in which I received them. The first one is about corporate services, EAs and porters, nutrition, looking for training and resources regarding this change. Can you advise on what support they'll be provided in terms of education?
Yeah, so maybe I'll turn over to Romaine. Maybe you want to pipe in. Are you on mute, Romaine?
Is that okay if I go ahead, Aaron?
Absolutely, go ahead.
Right, so there is plan with the educator for CSS that we will need to be providing support for that team. We recognize the team is crossing multiple sites, so all of this, I see a subsequent question about what's the timing. So there has been education unfolding today. The educators will be on the sites over the Easter weekend and will be going through the sites, providing the education. And we recognize customer supports and services, EAs, our nutrition delivery people need to be included. But also all of the links in the education material will be up on the hub. And honestly, some of the video materials that there are really, really simple to use, showing people just how to take a sterile mask off. So those resources will also be available to all our employees through the hub.
Great, thanks. Next question is, would it be possible and prudent for IT staff to use PPE during interactions with hospital staff?
Dominic?
It's Dominic, happy to take this one. Going back to the concept I explained as to why we are doing this, I think the answer is obvious that it's a no, because everyone around that individual will be wearing a mask. So they will not infect the IT person going to a ward and having interactions with a healthcare worker. So I would say there's no reason. They can be reassured. Key piece again, keep your physical distance, do your hand hygiene after touching an environment that may be contaminated. This will be the key things. And it doesn't matter whether that contact is a healthcare worker or whether it's one of your co-workers within IT. Keep your distance the same that you would do outside of the hospital.
So another question coming up here is, generally speaking, about where to pick up a mask for the day. Where does one, depending on where they work, get their starting mask for the day?
Les, do you want to?
Yeah, so I mean, that is, and I think I saw the question come from one of our physicians. I think at the clinical unit that you're most likely, or you start your day, is where you would pick up your mask. So we're asking managers, delegates to have the mask and kind of, they're the keeper of them, to hand them out to people. What's important is, so if it was someone going to C4 hematology, as you enter the unit, you take your mask and that same mask will stay with you for the duration of your day wherever you travel. I think we could probably revisit early next week if we need to put a different supply where a group of physicians might have their offices together. We could have that conversation early next week. But right now it was really making sure we had the tools on the frontline units where the patient care is.
So next question is, what about for if you are not patient facing, but are in an office inside an inpatient unit, would people in that circumstance also wear a mask?
Dominic?
Yeah.
Can you repeat the question? Sorry.
Yeah, no problem. So for someone that's in an office they might not be in a patient-facing role, but your office is located in an inpatient unit, would you also be wearing a mask?
Yeah, I think it really depends on the role. And I think these are the things that should be discussed offline with the manager or the people working in those areas. If that person is, for the most part, sitting in that office, the same thing would apply that I said for IT previously, that you can keep your physical distance and as such it will not be needed. If the physical distancing cannot work because of the type of work that person is doing, then a mask may be prudent. But to me, based on what I hear right now, it sounds like a role where you may not need a mask at this point.
So could the same be true for managers who are on a site, but they're not speaking with families? Like, what would it be for somebody who's in a unit, but the goal, if the goal is to protect from one another, do they need to wear masks as well?
It really goes down to what makes most sense for a unit. And if we go through each single role on that unit, it becomes more difficult. There are certain roles within a unit, and the manager may be one of them, who may not necessarily need to wear a mask given their role, but it's probably easier to say the staff on that unit is doing universal masking. There may be some exceptions with people working just in an office that happen to be on that ward, but otherwise, just to make it simple, we say we go by location rather than necessarily by role within that area.
So I imagine it's Kirsten, individual, like many of our leaders who are in clinical areas and others are doing huddles, our CQI huddles and so on, and are interfacing with a lot of our people on the units. So there it makes a lot of sense to put the mask on. It's in keeping with the principles.
Next question is about mass reprocessing. Will it occur will reprocessing also
Initial focus was on N95s. This work will continue to roll out over the next week or so. So right now, there is the first recommendation from the CDC in the States around conservation of equipment is that we actually reprocess with hydrogen peroxide reprocessing. We are in the process now of some units collecting. We are going to start over the weekend actually reprocessing those masks, but we are not redistributing them. We're keeping them as we're just being prepared if we got into really dire situation of not having equipment available, that we would have a supply of reprocessed. There's some guidelines out from Health Canada to help us along in that work. So the bottom line message is, if you have a team and you've been asked to date to collect your used N95 masks for reprocessing, please continue to do so. COVID positive or COVID negative doesn't matter. The masks will be reprocessed. We will not be re-entering them into the system unless we had to. So no change if you haven't had a communication. If your team's already been doing it this week, please continue to do it. We will reprocess them, sterilize them, and put them away. and we'll have them there if we actually got into a real shortage of PPE.
And how many, in terms of reprocessing, how many times can you reprocess a mask?
So that's a great question. You probably don't want the detail of all the answers. There's 4 different technologies that if people are looking at what's available in the literature, 4 different technologies. What we are currently doing today is hydrogen peroxide reprocessing, and that allows for a mask to be reprocessed 3 times. There's another technology with ultraviolet that actually allows up to 50 times. So we're working with the Health Canada guidelines and our equipment, and lots of work has happened in our reprocessing departments so that we're prepared that we have this strategy if we get to where we need it.
And the N95s are being collected, reprocessed. Is the same going to be done for surgical masks?
Yeah, you're taking me into next week's agenda. So yes, we will go there to collect just the standard sterile surgical mask. That will be conversation we'll make decisions about next week. Certainly the CDC in the States and Health Canada is giving us language that would allow us to do that. Again, right now, if people work with us and really work with teams on the messages of conservation and some of the other strategies next week, we have no plan right now of putting reprocessed masks back out. We know we can safely do it. It's in our back pocket.
And what about the issue if somebody wants to wear their own respirator, such as an N100 or something of that nature?
Dominic, do you want to take that one?
Yeah, just unmuted myself. Really depends on the role. If it's needed and appropriate for the area, we are still, I would say, we or employee health is in the process of how this would look like, because if you would be needing an N95 mask for the type of work you're doing, we want to make sure that your N100 mask fits very well. We wouldn't allow an N100 mask in a surgical suite, for example, because there's some concerns about sterility around it. So it really depends on the role and more to come, but it would probably need some level of assessment through employee health. At least that was the initial plan.
Yeah, and it's Kirsten. I think health, safety, wellness folks are pretty overwhelmed already with the N95 fit testing that we're doing. So not sure that they'll have the capacity really to address any of these personal devices, but we'll have to see where this heads.
And I've had a couple questions here about containers for staff for storing masks. Will they be provided? Are people suspected to bring their own containers?
So it's less. So the concept of the container is related to the reuse of a mask in the day. So I'm handed my surgical mask in the morning. When I go to coffee or break, you can, if you envisioned, I'm using generically a Tupperware plastic dish. If you put your face forward, you can untie your mask. It can fall into the dish. That's the way for you to protect and help conserve PPE. The expectation would be for staff to bring forward their own containers. Alternatively, if they didn't have that plastic container, the same thing could be done with the paper bag, and there are paper bags that we will have available on the carts. I go back to the messaging for the weekend is around people will be given a mask to use for universal masking. We will, with the help of our educators, re-support the concept of reusing in the day, which could be plastic, could be the paper bag. The bigger use around the Tupperware conversation might come later next week if we look at some of the conservation strategies.
And I have a couple of, sorry, was someone else responding? No, okay. A few questions here about why couldn't we pick up or distribute the masks at screening when someone arrives? Is there a reason that process wouldn't make sense?
Kirsten, I would say it's not a mask for everybody, as we've said, universal masking going to people who are patient facing and so on. So really it should be the unit that they're going to, the environment that they're in, and making sure that the right people are in fact getting the masks, and that we're not kind of creating expectations that everybody does get a mask. We're not at that stage yet. So it really is best that people get to the areas where they're working, and that's where the judgment is made.
So Erin, if I add in, it's Les again, our Toronto colleagues tried it at the front door and they went to handing them out based on the clinical units. They found that system worked better. I think we're doing this on the start of an Easter weekend. If we don't have it right, I think we're going to listen to people's feedback, and if we need to course correct as supplies change or we learn more about the processes, we'll take that feedback. What we really wanted to make sure is people understood what was the plan going into the weekend.
And just a quick question. I know it was addressed in the webinar, but what about rollout in terms of broadly educational support and the tiering of the rollout, how we're going to communicate this? I mean, as the VP of Communications, I can address a little bit of that, but just turning to our panelists here to talk about what's important in terms of bringing this change to the unit level over the next few days. Can you just reiterate what the process will look like in your mind?
So Kirsten, so we know communications, and Erin and team are very well briefed on this. It's a multitude of things. All of you would know that as leaders as well. It's written materials, it's simple visuals, it's using your huddle boards to reinforce messages, both on the board, but also in your safety huddles. It's that person-to-person contact that happens as well. So how do we really empower people to understand what's happening in their units? That's where the educators come in. But the more we can have people support each other, the better, right? And making sure that if there's some incongruence in understanding, that people raise the questions so they get the right answers. So this is not going to just happen with a one-session education. We all know that. It will be one of reinforcing messages and really creating safe spaces for people to raise the questions around, well, why do I see this but not this? And to ask even each other, okay, well, you're wearing a mask. Tell me more about it. Why are you wearing or changing from a surgical mask, for instance, to an N95? So again, it's about having people having conversations, but also, using things like the hub. And I know that not everybody can have access to the hub. That's why we're trying to make materials and things available to people in different ways, but try and encourage people to really look for that information. The hub's got a lot of great material that's there. Some of the visuals are there, and more will be coming to those locations as well.
So it's safe to say for those areas that don't currently have dedicated educator support, that they'll have some level of support as we roll this out.
Yes, and again, if there are areas that are really lagging, or you're feeling, okay, we're really not feeling prepared and so on, please communicate that right up to the clinical practice and education group, or you're free to send me an email as well. Again, because the educators don't necessarily cover all the areas, but they have really stepped up and have worked so hard to look at how they rally their effort and really try and spread across the organization. And of course, Julie Hoflack from CSS is a key partner in this as well. All of us, though, can be champions to this. So again, if there's information that maybe your team have a few champions that want to take this on, and if we need to spend some more time and energy with them so that they really can be great ambassadors on your units, happy to do that as well.
Wonderful. And so I can just address, I know there are some questions. We will have a communique that'll go out this evening. There will be a Q&A and some other resources that are produced to support this. And I think Kirsten's adequately addressed the rollout over the next few days. So I think we've addressed most of the thematic topics coming in the questions. Want to thank our panelists. Want to say that this webinar is recorded and will be available on the hub. And we'll continue to have webinars, as has been our practice for the last several weeks, and then we'll be able to address this topic as it progresses. And you can always forward questions to the COVID-19 staff email line. This is a big change, a progressive move, and a big part of our COVID-19 preparedness planning. I want to thank our panelists and everyone who made time for this urgent webinar this evening. Until we speak again, thank you and be safe.